Okay, in this section we're going to talk about the side effects of chemotherapy. Since we actually discussed these side effects in Nursing 112 with the cancer lecture, let's take it one step further by identifying the nursing diagnoses associated with the problems. So with the knowledge of knowing that chemotherapy attacks the bone marrow, we know that it can cause a decrease in red blood cells, and it can cause a decrease in white blood cells and a decrease in platelets. Okay, so with the decrease in red blood cells, what we find is the patient is anemic. So the nursing diagnoses associated with that would be like activity intolerance or fatigue, impaired gas exchange, ineffective tissue perfusion. These would be related to the decrease in red blood cells. When they have neutropenia, then they're at a risk for infection. Okay, and so we'll talk about the absolute neutrophil count in a future slide. Okay, when we're trying to calculate an absolute neutrophil count, we need to take the total white blood cells and multiply them by the percent of neutrophils plus the percent of bands. This is how we measure to see if someone is neutropenic and to determine if they should be placed on neutropenic precautions. If the absolute neutrophil count is less than 500, then neutropenia is actually considered. So what we need to do is we need to take this as an example. You have a total white blood cell of 1,000. Your neutrophil percent is 30%. Your bands is 5%. So you should take 1,000 times 0.3 plus 0.05, and you should come up with 350. Well, since 350 falls below the 500, then this patient should be placed on neutropenic precautions. Another side effect of chemotherapy includes low platelet count, which is thrombocytopenia. With our patients that have thrombocytopenia, they're at a risk for injury, which could be bleeding, risk for impaired tissue perfusion, cerebral if they have bleeding onto the brain, or ineffective protection. When you have a low red blood cell plus a low white blood cell plus a low platelet count, that is what we call pancytopenia, which is a decrease in all of the above. We also need to take in consideration the side effect of GI issues that the patient might have, such as taste changes, anorexia, nausea, vomiting, and even diarrhea. With that, we need to consider an imbalance in nutrition, less than body requirements. We also need to be looking at our fluid and electrolyte balance as well. And then there's the diagnosis of diarrhea. When they have chemoreceptor trigger zone, nausea, vomiting, or chemo-induced nausea, we need to look for risk for deficient fluid volume with those as well. When we have damage to the cells of the oral mucosa, it can lead into mucositis or stomatitis, which is what we discussed in Nursing 112. So that can impair our oral membranes. And what do you think we need to treat that with? That's correct, nystatin, swish and swallow or swish and spit to kind of coat the mucous membranes to help treat that fungal infection that actually occurs. Alopecia is another common side effect of chemotherapy where the patient will lose their hair. And with alopecia, there is a risk for a disturbed body image. We can help educate our patients as far as purchasing a wig prior to the hair loss, show them different scarves and different things that they can wear on their head, many different aspects, but addressing the risk for a disturbed body image is important. Chemotherapy can be used as adjuvant therapy. Adjuvant therapy is when the treatment that is given in addition to the primary or the initial treatment. So it's a treatment in addition to, more or less, to the primary treatment. And it's designed mainly to help reach the ultimate goal. Neoadjuvant chemotherapy is chemotherapy that is given prior to surgery to help shrink the tumor so that it can be surgically removed. So neoadjuvant is given prior to surgery, shrinks the tumor, and then it can be removed. Palliative chemo is used to relieve symptoms associated with the advanced disease, such as pain or what have you. And this is actually beneficial to improve the quality of life until the end is actually there. So when we look at chemotherapy, we must look at the dosing. And chemotherapy is guided by protocols. And these protocols are based on the results of controlled research studies. So it's very intense as far as the dosing. It's usually given in cycles, and it's really dependent on the duration, the frequency, and the number of cycles, dependent on the type and size of the tumor and whether cancer has spread to any of the other areas. What term do we use that means that cancer has spread to other parts of the body? That's correct. That's metastasis. So what is another factor in determining the duration and frequency of chemotherapy? And that would be the condition of the client itself. So let's think about it. If your client is suffering so greatly from fatigue that they can't get out of bed, then why would we not pursue giving them more chemotherapy at that point? Or if they're throwing up so bad that they can't even keep anything down, then they would not need more chemo at that point. It might be delayed. So chemotherapy can be one agent or a combination of agents. However, it is very unusual for just one agent to be used alone. Combination therapy is usually the norm. This is beneficial because it is able to kill the cells in all phases of the cell cycle, and it's more than one agent actually helps make this possible. So thus we kill at a specific cycle that the cancer is more apt to growing, and then we offer a non-cell specific to help cover the other phases. So usually chemotherapy is prescribed in more than one type of chemo, but again, it's all dependent on the cancer, the stage it's in, and the metastasis, whether we do one, two, or multiple agents. Okay, for the specifics of our drug classes in the chemotherapy or antineoplastics, I need you to divide them into antimetabolites, anti-tumor antibiotics, antimitotic agents, and alkylating agents. In the other category, what I want you to touch base on is the biological response modifiers, to include interleukin and interferon alpha. And then we'll go into our colony stimulating factors that we discussed in 112, which would include our erythropoietin and our numega for that. And then we'll finish up with your final recording to kind of tie it all together using nursing process.